Okay, so welcome back to the TRT and hormone optimization. And back with us as a guest from Australia is Dave Lee. Welcome, Dave.
Thanks for having me again, Stephen.
You're so welcome. So for the viewers, you can leave your questions in the chat box. Already 5 viewers there. And before we forget it, we should say happy birthday for Ali Gilbert. Happy birthday, Ali.
Happy birthday, Ali.
Okay, so she can click away now. Okay, I've already had a few questions under several videos last week, so I kept them especially for you. So
Sure.
one of them questions was, at what age should men that don't have any symptoms should think about getting their hormonal levels checked, thyroid, testosterone, and so on, just to have a baseline to compare with it later when they're 40, 45? At what age should they start worrying about that?
Yeah, that's a good question. I guess it depends on how well you're doing, because there would be two camps of guys. There'd be the guys who were doing really well and who were thriving, and the guys who are, not so much. So I think regardless from a prevention and like optimization standpoint, I think getting your bloods done every year or every couple of years is a good idea, even from the age of 18 to 21, whenever you want to start taking responsibility for that. I think if you start getting bloods done too much younger than 18, the measures that we have for hormone values during puberty kind of mean a little bit less. It's a little bit less clear. But I think getting your bloods done every year is a good, or every couple of years, and getting a comprehensive panel done, not just your hormones, but all your different markers, is a good idea. And especially if you're not doing well, I think getting your bloods done every year is definitely a good idea. So yeah, I mean, I'd say from 18 to 21 is a good time to start getting it checked. I started getting my blood work done when I was about 21, 22, and that was very useful for me, who started HRT at about 25, to be able to see that, okay, there was a trend that was emerging in my early 20s. So I think the earlier you can start, the better. But I do also caution guys, like, don't get too obsessive about getting your blood work done. Like, I've seen some guys go down a bit of like a dark rabbit hole with, like, becoming obsessive about it. I think every year is good.
Okay, that's good advice. Another question was about the use of PEDs. Yeah, nowadays a lot of young men that go to the gym are already into using all kinds of performing enhancing drugs, peptides, anabolic steroids. And the question was, can you guess or give an estimate that are using PEDs if they are going to get onto TRT? Is that almost a certain thing, or does it depend on the cycles they do, on the compounds they use? A lot of them do post-cycle therapy, and does that give a guarantee that you always will get back your testosterone levels, or will they get onto TRT eventually?
That's a good question. There's definitely not like a clear yes or no to that. Absolutely not. So there's a lot to go through there. So the first question is, like, if you do cycles, are you inevitably signing up to doing TRT for life? No, definitely not. That's not a hard and fast yes. This is absolutely what's going to happen. You are going to compromise or ruin your production for life. No, that's not a thing. But you are rolling the dice with that, and then there are factors that will influence the outcomes of that equation. So from what I see, like how young you are, like doing it before the age of 25, that has a higher chance of messing up your natural recovery, just from what I've seen. The literature may say otherwise, but in reality, doing cycles under the age of 25 seems to have a higher rate of messing up your natural production long term than starting in your 30s, for example. But that could be confounded with other factors, which is my next point, which is that there's something going on with the younger generation of guys, like under the age of 30, who are having these low hormone issues that aren't to do with messing their bodies up with doing anabolic steroids when they're young, and it isn't from being obese. Like, there's a cohort of young guys who are coming through who just have low hormone values, even though they're doing everything right. So I think there's a lot of guys who are coming into doing cycles when they're like 19, 20, 21, 22, and their hormones are already shot. They just maybe don't know it. Maybe that's what's driving them to wanting to do a cycle, is they're getting subpar results in the gym because they've already got terrible hormone values to begin with. So if you've already got potentially a compromised foundation of your hormones, which you may not know, if you're 20, 21, 22, jumping on like a 500 test cycle for 12 weeks, you may not have, testosterone values from the last couple of years to actually see that you were low to begin with. So, then you do a PCT and you beat yourself up because your levels are low. Maybe your levels suck to begin with. So that's another factor as well, is what are we dealing with in terms of the foundation? So I see everything across the board. I see guys who've done, a cycle a year, every year for a decade, and their hormone values are fine. I've seen guys who do one cycle, and I don't mean to fearmonger with this, but the 5 lowest testosterone values I have ever seen have all been from SARMs, and they've all been from guys who are under the age of 25 who have all run a PCT. And they're coming back with like a total testosterone that's like almost undetectably low. So in the reference where we're using like 200 to 700 as the reference range, I'm talking like a total testosterone of like 3 or 4. In the Australian units that we use from 5 to 25, these guys are coming in with a 0 at the front, 0.1, 0.2. And this is crazy because these guys will have been going on that low since they finished their cycle and since they came to see me. That could be 1 year, that could be 2 years, that could be 5 years. So there's a lot of variables to unpack in terms of if someone's using PEDs, are they going to need TRT in the future? I would say that if you're using PEDs, you're probably going to be in the market for TRT in the future because you're wanting to maintain the natural level of what you're cycling with down the track. Like that to me makes a lot of sense as well. But you're definitely increasing your chances of needing exogenous hormone support. The more you cycle, the higher the doses you use. I would argue the more exotic compounds you use, because we just don't have the research. But yeah, the younger you are, the more you do it and the higher doses you use, the more likely you are going to need exogenous hormone support when you get older. Absolutely. But would you have needed it anyway? Hard to say.
Okay. Yeah. I didn't know that. From SARMs, that low from...
And S23 has been the one that's messed people up from what I've seen. So that's just the trend I've noticed.
Okay. Thanks for sharing. Okay. Then recently, a video on the channel from Justin. He made a video about Tellme sartan. I don't know if you have any experience with it. Recommended it as a good protection for bodybuilders that do a lot of cycles, protective on the heart and so on. Do you recommend Tellme sartan on TRT?
Yeah, that's a good question. So when it comes to the blood pressure medications, telmisartan is always going to be my preference. Look, in terms of using it for guys on TRT or bodybuilders, I think we've kind of got 2 cohorts there, because one group we're dealing with super physiological exogenous doses of hormones. So if we're going to be dealing with that, then hypertension often comes with that territory, in which case you'd be looking at it as like an ancillary for running a cycle. I think if you are going to be doing that, I mean, firstly, I would caution people not to need ancillaries like that. So like, don't do a cycle that jacks your blood pressure up super high. But with that said, I mean, it's kind of hard to say. Sorry, I've just got some disturbance in the background. Just give me 1 sec. Sorry, the internet's cutting out. I just might need to just after this question, I might just change some stuff over and I'll come back. But when it comes to telmisartan in terms of using it for TRT, it's always my preferred blood pressure medication, and it's because the ACE inhibitors I find aren't as effective, but they also tend to upset the stomach more. So telmisartan is my preference because it's an angiotensin 2 receptor blocker, so it's more mechanistically effective than the ACE inhibitors. It's got a long half-life, so it can be taken once a day. And it's also got a PPAR agonist property, but that's very mild. That's kind of just going, okay, well, this is the preference over the other sartans, but I'm mainly looking at it for the longer half-life. But if someone's got hypertension on TRT, that is a problem in and of itself that needs to be unpacked. And throwing, 40 to 80 milligrams of telmisartan for someone who's maybe taking a few hundred milligrams into supraphysiological territory on cycle is very different to someone who is 20, 30, 40 kilos overweight, who's highly psychologically stressed and has poor cardiovascular fitness. So one is kind of like an ancillary because it's like, well, this is the territory that you've chosen to play in, which I don't recommend doing from a health standpoint, but if you're going to do it, then that's a good thing to do. But if we've got hypertension on TRT, that's something that usually needs to be addressed. And it's, from my experience, the vast majority, and I mean 95% plus, there are exceptions to the rule, absolutely, but 95% of people with hypertension on TRT are either overweight or psychologically stressed or both. Usually it's both. So my preferences for hypertension to start with is a combination of ubiquinol, which is like a bioavailable version of CoQ10, and phosphatidylserine, which reduces cortisol. So using those two things together, ubiquinol, Neil Rouzier talks about using ubiquinol for blood pressure, actually, or CoQ10 for blood pressure. But using a heart-based antioxidant and something to lower stress together with cardiovascular exercise and also CBD oil if it's accessible. They're my first preferences for an adjunct to hypertension. And then if someone is still hypertensive and they are exercising, they are working towards resolving the root cause and they're not there yet, absolutely telmisartan. I don't usually find 40 milligrams is enough to move the dial if we've got a problem. Usually we need 80. And I would prefer someone use 40 to 80 milligrams of telmisartan with 100 to 200 milligrams of ubiquinol and 200 to 300 milligrams of phosphatidylserine, then use like 160 milligrams of telmisartan. So I'd prefer to reduce the load of the pharmacy and increase the dose of stuff like antioxidants and other strategies for reducing blood pressure. But as far as medications go, I mean, I put it in the category of something like Cialis, which is like, it's not as, I wouldn't put it in that harmful category as other pharmaceuticals, but I just caution people in terms of using something that, it's important to use for a limited period or not to give a free pass to go, oh, okay, well, now I've got, decent blood pressure, even though I'm 30 kilos overweight, because that 30 kilos overweight is still going to come back and bite you in the ass later.
Okay. But for someone on TRT that is not overweight with 140 over 90, so limit high blood pressure, so tell me a good option there.
Yeah, I would say so. I mean, again, I'd be looking at the ubiquinol, phosphatidylserine, CBD oil, more cardio, mindfulness, meditation, those kind of things as a primary adjunct. But yeah, if they fail, absolutely, for sure. It's more like
yeah. And what about tadalafil?
Tadalafil for blood pressure. When you look at the studies on how much is needed to actually make a significant change in blood pressure, 5 milligrams a day of tadalafil doesn't do much for blood pressure. The main thing that I find that tadalafil does, or more so doesn't do, is it doesn't make the situation worse. So a lot of people think that, something like, Cialis, tadalafil, or Viagra, sildenafil, if you take that and, maybe you're overweight already and you've already got high blood pressure, that it will make that worse. No, it will actually make it better. These medications are actually primarily, they will primarily lower your blood pressure. But in terms of like a 5 milligrams a day of Cialis, how much of an impact will that actually have on hypertension? Very few. Maybe you might drop a few points, if that. But generally, I find that you need to go into the 10 to 20 milligram range of Cialis to get a good blood pressure lowering effect. And I found personally that 80 milligrams of telmisartan is more effective and better tolerated than the higher doses of tadalafil.
Okay.
Also cheaper.
That's clear. I have one more question before I go to the questions in the chat box. You wanted to change something to your setup before we continue?
No, it's all good. It was the connection was a bit dicey, but it seems to have cleared up.
Okay. One more question that I got recently under a video. Are there differences in testosterone levels and the need for TRT later in life between the different races, Asian, African, Afro-American? Have you any experience or knowledge about it?
I actually don't know. That's a good question. I've done some kind of research in terms of the difference in 5-alpha reductase expression in genetics and ethnicity, but I don't remember it enough to quote it because I'll probably get it wrong. But there was a difference in androgen receptors. There was a difference in enzymes related to hormone metabolism that trended across different ethnicities, but the directions that it went in and what those trends are, and if they were even significant, I can't remember enough to actually say with any kind of authority.
Okay. Looking at David, hi there. Have a great weekend, man. It's one of my patients. A question from one of our chat. How high can EVF hematocrit get before needing to donate remove blood on TRT? Reference 1.50. A question we get very often.
Yeah, the question that I think we've all probably answered a million gajillion times. But it's a good question because it probably comes up on everyone's radar at least once, whether it's a legitimate reason for it to come up or not. But it will get inevitably, which should be, fucking damn well should be reviewed at least every year when you're on TRT. You should have your red blood cell count reviewed. So it's important to know what's going on. So it completely, I think the answer to this question, it completely depends on who you talk to. Whoever's giving you the advice is going to impact the answer to this question. So the way that I look at it, and this is one of the big overarching kind of practices that I have in terms of how TRT is done, is that if you can't put a dose or amount of testosterone into a man that can't tolerate it. So if you've got someone who's, let's say, 19 or 20 or 21 years old, younger than the guys I work with, but let's say that someone's working with them on their treatment, and they've never had high testosterone to begin with. They were obese during puberty. Maybe they had some kind of, injury to the testicles or something like that, but never went through full development. They're currently obese. So this is an extreme example, but I'm using it to illustrate a point. So if you take that guy and just jack his free testosterone up to, like, let's say a 50 or a 1500 in Australian units, so double the top of the reference range, a number that a lot of guys need to get to. If you jack him straight there, he is not going to be able to fucking tolerate that amount of testosterone, because there is no way in hell that his body in that metabolic inflamed state, where even if he did have the hardware to make it, it would be completely and utterly suppressed because of all the stressful processes going on in his body. You can't dysregulate the body's rhythms like that and work with it in a way that you're working against the body. So you have to work with the body. So if you've got someone who has low testosterone and they're not able to regain their optimum amount for whatever reason, and they're currently not in a state of good health, the amount of testosterone they can tolerate is going to be very different to the amount of testosterone they can tolerate and do well with if they're like 8-9% body fat, looking after themselves well, sleeping well, exercising every day, doing all those things right. So we have to work with the body to a degree, and it's only when you work against the body that you start to get problems. So this is one of the problems that you'll get, is your hematocrit will jack through the roof because your red blood cell count is going up to beyond a level that your body can naturally should be tolerating. So you have to be doing something wrong for the body to jack its hematocrit so high that you have a problem. So if this does come to this point, it means that your dose is too high, usually for how overweight you are. That's usually the issue. But usually the problem isn't that your dose is too high. The problem is that you've got too much body fat. Or the problem is a bad protocol, like inconsistent injections, all kinds of other things that could be causing issues. So, you want to be injecting frequently. You want to make sure that your diet's good. You want to make sure that you're looking after yourself right. You want to make sure that you're doing everything right. But your hematocrit could become part of a problematic cascade if you're obese and you have you're jacking your testosterone level too high. Yeah. So I don't think there's a number that causes problems though, but there's definitely a point where you'll get symptoms of it being too high. I've only had it happen a couple of times, and it was both guys who were obese. But yeah, if it gets into like the 0.54 to 0.57 and you've got symptoms like your face is turning into a turnip and you're getting problems, yeah, it can definitely be an issue, but it doesn't happen very often. When this is being done right, you're doing, 2-3 injections per week or daily injections, and you're looking after yourself well, and you're moving your health in the right direction. Even if your health isn't perfect now, but you're moving in the right direction, you shouldn't be having problems with elevated red blood cell count. So by and large, it's not going to be an issue. The only time that you're going to have problems is if your health is out of whack or if your protocol is just way off.
Yeah. Right. How can a guy improve sperm? Is there any medication?
I'm not an expert on that, but in terms of improving your sperm parameters across the board, it comes down to improving your overall health. So if you want to improve the quality of the genetic blueprint that you are passing on to the future generation through your sperm, which is basically the key to unlocking, the path forward for your bloodline, is that you have to be expressing yourself and your way in a way that your epigenetics are expressing their best possible pattern. So low inflammation, low body fat, good quality diet and lifestyle practices, low stress, ideally no pharmaceutical drugs. All of these things are big factors. And these are big factors that influence the epigenetics of your offspring for years prior to conception. I mean, most people, when you think about the months prior, but we're looking at years prior here. So everything that improves your overall health is going to improve the parameters of your sperm. So that they would be the things that I would be looking at. What is going to give you all the things that are going to improve stuff like longevity and anti-aging? All those things are probably going to improve your sperm parameters as well, but not an area of expertise for me.
Great. For the viewers, leave your questions in the chat box. I will pick the best ones out. Expiry dates on pharmacy testosterone. He says Bayer Testoviron. Can I use the ampules that expired a year ago?
I definitely can't publicly green light using expired medication in terms of like best practices for health and all those kind of things. But what I will say is that if you're looking at the expiry of an oily testosterone solution, if it's in like a glass ampule, which like I'm assuming we're talking like similar to like the Sustanon ampules, like the 1 ml glass amps. Usually the thing that will break down in a testosterone product is going to be the rubber stopper before anything else starts to break down. So you're going to get more longevity out of amps than you are going to be getting out of vials. I personally don't think you would, and this is just a hypothetical theory, I don't think you would run into problems using testosterone that's expired a year ago if it comes in a glass vial, but definitely wouldn't advise using expired medications in general.
Sure. What are some blood markers that may be indicative of cancer?
Cancer markers would be the main ones to look at, but an elevated CRP, elevated liver enzymes would be the first sign. Your white blood cell count can be out as well, but an elevated CRP is usually the first thing I'm looking at. And if I can't, this is just the way that I do things personally, because we have to check cancer markers privately, that costs money. So I will generally, I run CRPs as part of my annual blood work or 6 monthly blood work. If CRP comes back elevated consistently and we don't have an identified root cause as to why it is elevated, I'll get cancer markers done. I'm yet to pick up cancer from running blood tests like that, though. It's just me being more preventative. But when I have seen cancer pop up in my clients, when it's been picked up by other practitioners, like if I haven't been working with them for a period, it's usually been hallmarked with an elevated CRP. But you can run blood tests for cancer markers.
Sure. Starting up TRT, Dave, but before we do that, maybe you want to say something about your ebook about TRT?
Oh yeah. So I haven't really done much self promotion. I'm not really a self promotion kind of guy, but a little while ago I wrote a book called TRT 101. It's an ebook. It is designed to be short, sweet, straight to the point. It's not a what is TRT and everything about TRT. That book, in my opinion, has already been written. It's Jay Campbell's TOT Bible. It's phenomenal for that in terms of being like this is what TRT is. So I didn't write that book. I wrote this is how I do TRT. So this was basically my way of, I'm currently very booked out in terms of my capacity to take on clients. So I wanted to kind of put out my blueprint and my roadmap to how I do TRT for people in a way that people can just read it, digest it, refer back to it, understand it, and kind of dial themselves in. So I wanted to make it super accessible for people. It's like 30 Australian dollars. And yeah, it's basically the approach that I have. It's not a cookie cutter approach, but it is a templatized approach to how I do TRT and the way that I've come to do it over working with guys in the trenches for the last 2 years straight, which when you look at all the other providers in this group who've done the same thing, we've basically come to pretty much the same approach for the majority of cases, which is really cool. So thank you. What was the question?
It's a great book, by the way, guys. What do you think about the approach of ramping up doses of TRT, let's say starting with lower dose 100 milligrams a week versus going up higher 200 milligrams a week and then trying to lower it down until you find the right dose?
Right. So I used to have a different approach to this. And I think it's always good to recognize that our approaches change as we get new knowledge. So I used to be of the approach that it doesn't matter if you start high and work down, or start low and work up. The end destination is the same. So I used to be comfortable with people starting on 200 milligrams a week, 120 milligrams a week. It didn't really matter to me too much as long as it was consistent. What I found is that for the majority of people, 200 milligrams is too much to start with. It doesn't mean that it's going to cause problems. So if you're watching this and you've started on 200 milligrams a week, it doesn't mean to second guess your provider or go back. It just meant that for me, when I looked at people who were responding on average, which is what you get when you just work with enough people, I found that 140 to 150 milligrams a week was a good starting dose, because that generally took people to basically the top, well, just in terms of, because we all use different numbers, about the top of the reference range or just over for total testosterone, which at 8 to 12 weeks is a good place to start. A lot of the time we titrate it up, but usually that's double to quadruple where the individual was 8 to 12 weeks prior, which is plenty to start with. And then I prefer to titrate up very gradually over 6 to 12 months. So, and this is all detailed in the book, but the reason why I like 150 or 140 to start with is because if we do daily shots, 20 milligrams a day, 140 a week. If we do twice a week shots, 150 milligrams, which is 75 milligrams twice a week. If we do 3 times a week shots, Monday, Wednesday, Friday, then it's 50 milligrams, 0.2 of a mil, 3 times a week. So 140 to 150 milligrams a week is how I start people off. And then I will generally titrate the dose up by 5 to 10 milligrams per shot. So it's just that's the easiest amount to adjust on the insulin syringe. So if they're doing, 2 shots a week, we want to bump it up, cool, move it up by 5 to 10 milligrams per shot. If they're doing daily shots and the doses come in a bit low, we'll go from 140 to 175 a week. So 20 to 25 milligrams per day. So I prefer to start people more at kind of like, it's basically about you're throwing a dart at the dartboard, but everyone's bullseye is going to be different, and the darts are going to be a bit different, and the board's different. It's all a bit different. But I find that 140 to 150 milligrams is going to get me the closest to the bullseye if I give it to 100 guys. And now some guys, it's going to shoot them through the roof. Some guys, it's going to barely move them enough. We are going to get hypo and hyper responders, but in general, I find that works well, and then I prefer to titrate up. The issue is that if you take someone's levels too high too quick, they'll get side effects, and that will generally be acne, cranked up central nervous system, water retention, mood issues, and depending on people's baseline mental health, that can cause a bunch of problems. So I like to frame it to the individual as about giving your body time to adjust. Puberty takes time, change takes time. I think a lot of people are in a real rush to kind of get to the end game. And guys, like it doesn't, like if you think a 1500 free T is going to change your life and make you into a better man, it might do, but it won't do it in 12 weeks. It doesn't matter what the dose is, you're not going to resolve your low T symptoms in 12 weeks. So I prefer to put a good solid amount in there and then gradually titrate it up over 6 to 12 months. And I find that works well for most people.
Great. I have no idea what the next question means. Maybe you do, but I will read. What types of low estrogenic testosterone would you recommend for long-term TRT? Low estrogenic testosterone. Maybe you want to say something about that.
Yeah, okay. So when it comes to the estrogen thing, I've done I've done a lot of different content on estrogen over the years, and I'd say my most concise one is on Danny's channel, which is like a 10-minute kind of rant on estrogen. Which is a good one to look at in terms of what the aromatase issue actually is. In terms of, in my opinion, it's an exposure to xenoestrogens and issues from also long-term malnutrition from having a poor diet for multiple generations. So that's more the angle that I kind of look at that. But if you're looking at ways to better manage the body's androgen to estrogen ratio on hormone replacement therapy, which I think is a fair thing to be looking at. It just isn't as arbitrary as using things to inhibit the enzyme. It's about what is going to be the lowest inflammatory state my body can be in, what is the healthiest metabolism I can have, and how can I best express my androgen receptor density. So that's done through diet and lifestyle. And then it's also in terms of having stable androgen to estrogen levels is basically going for more frequent administration. So we know that peaks and valleys are going to cause problems because estrogen is made, as Jordan and Gil often say, paracrine hormone is made on demand. So if that's going to be constantly being made on demand at a certain rate, you want your testosterone to always be stable. Men are not meant to have big peaks and falls in hormone levels over the course of a month or weeks. That's for women, not men. So, 2 injections per week, 3 injections per week, daily injections if needed, twice daily cream if it's needed, but more frequent administration, lower body fat, which is a frequent thing I keep coming back to, but it's a big problem for a lot of people is it's just excess body fat, a few diet and lifestyle changes that need to be tweaked. They're the things that people need as opposed to the 0.25 milligrams from Rivodex twice a week. It's the couple of supplements and the couple of cleaner meals and the extra 2 cardio sessions a week for 12 weeks or 16 weeks. It's that needed over time as compared to something else like a medication.
Any tips for PIP, post-injection?
Yeah, so a big part of post-injection pain is, well, firstly, it's having the body get used to what you're injecting into it. I remember the first time I think it was the first time I had a primatestin shot, which is testosterone and anthate in castor oil. I got it in the glute from a doctor, and I felt like I'd been shot for a week. I couldn't walk properly the next day. And most people report something similar, especially if they use, I think at the time they used a 19 gauge 2-inch fucking harpoon or something like that, which was fair, why I felt like I'd been shot. I'd been hole punched, but using a smaller needle is a big one. When you're first injecting, it's very normal to kind of have a bit of a tremor or a shake. So you could be aggravating or pissing off a whole bunch of the muscle tissue when you're actually doing the injection. And then also, relaxing the muscle as well. If you're tensing it up and contracting it, you could cause more trauma as you're doing the injection. But the main issue with PIP is that your body has to get used to the compound that you're injecting. So the first time that you inject an oily compound into a muscle, the first few times you are going to get post-injection pain. That's just part of your body adjusting. That's totally normal. And then the first few times you inject a certain oil or a certain compound, you may get more pain as well. But if you're consistently getting post-injection pain, you're using small needles, you're doing everything right, I would wager that you're not using pharmaceutical testosterone.
Right. A question that will be addressed by saying that the question is it true that after TRT, testosterone level doesn't come back to normal, but there is no after TRT, I guess.
Yeah, so the interesting thing, right? So someone put up a study a while ago. I was talking to someone in a group about this. It was a bit of a debate because the evidence that they were citing was actually what they were citing was correct in terms of what the evidence said, which was that it was some study. I can't remember the study, but they took a group of men, they gave them exogenous testosterone, and they found that after, I think it was 6 to 12 months, all their levels came back 100% of where they were before. And it was basically saying that the argument that the individual was using was that anyone can do a trial of TRT to see if it helps them because it's not going to impact their levels if they stop taking the treatment as per this study. Now, working in the space, we know that 100% of people who use exogenous hormones do not regain 100% of their natural hormone production. It just doesn't happen. If it did, we'd have a whole bunch less guys who previously used testosterone who would be on TRT. We'd have a whole bunch less. Now, yes, a whole bunch of guys, they are using analogs. They are using super physiological doses. They are using all these different things, 100%. But there are plenty of guys who've just done test cycles, who've either done a PCT or haven't done a PCT. This study didn't use a PCT. And they have messed up their natural levels because when you do disrupt the HPTA system, when you restart it, it can be compromised. Now, you may not lose 20% of your production. You may not lose 30%. You may only lose 5%. You may lose 10%. But that is still enough that can cause an issue. And if you do that multiple times, you can definitely cause problems. So if you're going to go on TRT or run a cycle for a period, let's say 6 months, a year, 2 years, 3 years, and then you come off either doing a PCT or allowing your production to start naturally, some science will say that there's not going to be any problems doing that. But the reality and the practice of it is that, one, if you have good natural production in the first place, you shouldn't be on TRT. So it's a moot point anyway.
Exactly.
But secondly, if you do disrupt your system for a period of time, you have to look at the age-related hormone decline that you would have over that period. And I would argue, based on my experience, that the longer that you disrupt your natural production or you disrupt your natural cascade, the more of a detriment that you will have to recovering your basal natural production. Now, I have seen guys who've been on TRT or who've been, permacycling for a decade, and they regain a pretty decent level. There will always be exceptions to the rule, but exceptions do not prove the rule. And the majority of the time, if you do use androgens for an extended period of time, you will cause some degree of negative ramifications to your natural production if and when you choose to restart it.
Sure. Dave, is there such a thing as testosterone flu? I know Gil has already answered that question in a video that is on my channel, but under that video, there are more than 100 comments, all saying this guy knows not, experienced it myself. It has nothing to do with anxiety. It's a terrible video. They missed the boat on this one. Everyone will tell you there's such a thing. We've all experienced this. So testosterone flu, what do you think?
Yeah, so that's a good question. So what was Gil's take on the topic? I haven't seen the video.
He said it not exist. He said it's just a bunch of anxiety, really.
I was under the impression that testosterone flu was from bad quality, like underground steroids. I thought it was from injecting things that were contaminated, because if you inject something that is not sterile and not clean into the body, you will get subjective immune system responses. And if we're looking at flu responses, I mean, the symptoms of the flu is the immune system responding. So I would take those things as meaning that your body is reacting badly to the compound. Now, I would also argue that the individual could be allergic to the carrier oil. That does happen like 1 in 100 times. It is rare. I've seen a couple of guys react badly to everything, but again, we're looking at the 1 in 100 thing. But when it comes to testosterone flu, I would say that it's a negative reaction to non-sterile, poor quality underground steroids or underground testosterone. Or it could just be a response to someone doing their first injection of testosterone, and it can be psychosomatic as well. That's a big one as well. Guys need to realize that when you do take your androgens up, it stimulates the central nervous system, and how you respond to central nervous system stimulation is based on the individual. Some people may perceive that as anxiety. If you have an autoimmune condition, it could ramp up the immune system as well. So there are lots of things intertwined here. People shouldn't downplay the effects of their psychosomatic responses to things. But yeah, I don't think that in general, testosterone flu, as in flu from pharmaceutical grade bioidentical testosterone, is that a thing?
Yeah. Someone wrote, immune system reacting to foreign hormones being injected into your body. Yeah, especially if they are not pharma grade. I guess if they are, of course, you can get some feverish reaction. 100%. Yeah, a lot of comments there under that video. Another question: is there such a thing as TRT? Because we all know maybe that's psychosomatic as well. A lot of people get improvement very rapidly in the libido section and so on, but then again after a few months that declines again. So what is your take on that?
The honeymoon period is really interesting. It's one of the most difficult things that I have to manage with clients, because I work with so many guys starting their TRT or inheriting guys within the first 12 months of starting their TRT. And the honeymoon period is one of the most difficult things to navigate because of how it pops up for different people. So one is when people don't get a honeymoon period, they freak out. So they go, oh, okay, I'm I'm 8 to 12 weeks into TRT and I don't really feel that much. Maybe I have a bit more energy in the gym. I wake up a bit better. Maybe I have a couple more morning erections a week, and they think that something's wrong. They go, oh, my dose is too low, or I need to do this. No, that's normal. You're actually meant to only, I say, look, if you're 10 to 20% better after 8 to 12 weeks, that's what we're looking for. That's the right thing. That's a perfect, typical response. So some guys will freak out if they don't get a honeymoon period. So nothing wrong if you don't get a honeymoon period. It doesn't mean, oh, let's crank the levels up. It just means the body needs time to adjust. We're going in gradually. It's working well. Now, some guys will get a very remarkable honeymoon period, and they'll either get a honeymoon period within the first couple of days of doing their first injection, or they'll get a honeymoon period for the first 4 to 8 weeks. Now, one of the theories is that it's around, oh, your natural production's still going, and then when your natural production drops off. I have not seen any research, any evidence to show that. When guys pull lab work after a week or two, there's a doctor in Australia who gets guys to do bloods after 2 weeks. I don't know why, but FSH and LH are 0 after 2 weeks. So I don't think it has to do with the natural production lingering. I think that's false. I think it's to do with dopamine. So testosterone, androgens in general are dopaminergic. Androgens regulate the dopaminergic system. Now, there's lots of ways that dopaminergic system works. It's not just more dopamine equals better. You've got dopamine creation, you've got dopamine metabolism, you've got dopamine synthesis, you've got dopamine receptor activity, you've got dopamine reuptake. So there's lots of different categories to this. And what androgens do, thyroid does it as well, is it facilitates androgen transmission, which means more in, more out, capacity for more. So if you're constantly here and your body has no idea that you're about to start TRT, your body is blind, your body is just operating the way that it has been for the last X amount of days, months, weeks, years, whatever. And then if you're going to come in and jab, 100 milligrams, 200 milligrams of testin, whatever, for your first jab, your body had no idea that was coming. So what's happened is now your dopamine transmission has massively increased, but the body hasn't built the machinery yet to be able to handle that increased dopaminergic transmission. So you're going to have more flowing before your body has the capacity to be able to know what to do with it. And that can be euphoric, which is nice because it's like, okay, now I felt like shit for ages. I've had all these low energy, hypogonadism, drained emotionally, spiritually, physically, sexually, in all kind of aspects. And now it's like, okay, now I've got some fire. Now I feel good. And then that pitters out after 6 to 8 weeks. And then people go, oh, what happened? I want that back again. That is more chasing a dopamine spike. And that's the thing that people need to understand and go, okay, that gave you a preview of what you could feel and experience day to day if you do everything right. And what guys need to learn is they need to go, okay, testosterone is going to be able to facilitate me feeling that way, maybe not quite the honeymoon way, but close to that way all the time, but I have to work with it. And the thing that I come back to that a friend of mine trained me in terms of working with people a while back is this idea of meeting the medicine halfway. In terms of you can't just inject your testosterone and expect to, get jacked straight away. You've got to inject your testosterone and then you've got to go to the gym. You've got to meet it halfway. Well, it's the same for how you feel. It's the same for how you wake up. It's the same for your mental point of origin. It's the same for all these different things that you want from the testosterone after you do your injection, the outcomes that you're looking for. The outcomes that you're looking for will be facilitated by the TRT, but it's how you meet the medicine halfway to get the outcome that you're looking for. And it's not about just sitting down and doing your testosterone injections and going, oh, it takes a year to work. It takes a year of you actually meeting the medicine halfway and showing up to get the results of being a high testosterone male after a year. So time is a variable, but time is really just opportunity to do work that you need to do. And that there is usually a point that guys get to on TRT. Some guys get it straight away. Some guys take a couple of years to get it. But there is a point where people go, oh, I can't out protocol this. I can't find the magic X milligrams of this or whatever milligrams of that to get what I'm looking for. It's the discipline, it's the diet, it's everything habitually stacked consistently over multiple times that gets what people are looking for.
Yeah. Is it possible to do from too high test levels when on TRT if you don't control estrogen?
If you just delete the don't control estrogen part,
Exactly.
then the answer is still yeah. Yeah, like absolutely. Like there's a misconception that the more androgens you have, the higher your libido will be. Like it's like the more test you inject in, the more supercharged your sex drive will be. Guys, if you're looking for that reaction, you're not looking for testosterone. You're looking for other stimulatory drugs like amphetamines. Like that's what you're looking for, and that's not a road you want to go down. So you can't just jack your test up through the sky and expect to just be constantly like a horny teenager 24/7. It's not productive. The body doesn't work like that, and it's never going to happen. So it just doesn't work. So if you jack your levels too high for testosterone, some guys do get a supercharged libido, but other guys get a reduced libido. Other guys find that once they take their levels beyond where their body is thriving, which is where we try to get it to on TRT, that their libido actually goes down. Now, why is this happening? I think it's because the nervous system becomes overstimulated. I think sex and sexual function is a parasympathetic nervous system dominant state. And if you're constantly jacking up your central nervous system because of too many androgens, I think it would be too difficult to relax to actually express any kind of sex drive. And I think that chronic stress state would reduce libido. But it comes down to how each individual is biochemically unique in terms of how they respond to these high levels of testosterone. But again, it comes down to, well, how healthy is the individual? If I take a guy who's thriving, who's super healthy, who's lean, he's been doing everything right for years, and I take someone who's 20, 30, 40% body fat, who's not looking after themselves, and I give them both 500 milligrams of test a week, I think we're going to get very, very different responses. Now, someone would go, oh, well, estrogen's the problem with this guy. You can throw all the fucking Arimidex you want at him, but he's not going to feel as good and function as well as this guy. It's not just because that person's broken and they're just making too much aromatase. It's just one of the many things that goes on when the body is in this inflammatory problematic cascade, and people can't expect to feel and look. The problem is people want to feel and look and function like this guy without doing any of the work this guy did to get there. And TRT is not going to do that. All TRT is going to do, and this is why I love working with TRT so much, and this is what excites me about working with TRT in the health space, is it's not going to do all that work for you, but it's going to give you the capacity to be able to do that work. Because guys with low testosterone, and these are guys who have it genetically, who can't, and when I say genetically, I mean because of how they've been brought up in such a polluted and non-ancestrally consistent world. It doesn't matter how hard these guys nail their diet, training, everything. They will not get the results they deserve unless they fix their hormones. And then they fix their hormones, and then all of a sudden now they can actually get the results from the work that they've been putting in. That's the thing that's really satisfying, is people get what they deserve.
One of the last questions there, Dave. What do you think of Tonkat Ali supplements? Is it worth trying first before TRT?
No, Tonkat Ali is bullshit. Tonkat Ali has been bullshit for a long time. And Tonkat Ali will continue to be bullshit for a long time. Tonkat Ali was the joke of the... when I got into health optimization, it was from the first book on testosterone I read was Christopher Walker's book. I can't remember what it's called, but it's all about naturally improving testosterone levels. It's stuff that all stuff that's still consistent to this day. In terms of stuff that's just good for you in general, in terms of how to train, how to eat, how to move, all that different kind of stuff. But even back then, people knew that Tonkat Ali was bullshit. When I first got into the testosterone space in terms of working with TRT in like 2014, 2015, Tonkat Ali was the butt of everyone's jokes back then, because it was bullshit back then. So just because now there's a new marketing push behind it, there's new people selling it, it's still the same snake oil as it was before. Tonkat Ali does not increase your testosterone production. It doesn't. Now, my theory, and this is just my theory in terms of I've read the research on Tonkat Ali. Firstly, I don't think Tonkat Ali is well studied in humans. I don't think there's enough safety data to suggest that people should take it chronically. Not enough safety data. And I'm not even going to get into Fedosia agrestis because that has not been studied in humans, period. So it's not safe in humans. So when it comes to Tonkat Ali, I think Tonkat Ali is a phytoandrogen. And that's just my theory. That's not substantiated. I don't have a citation for that. That's just my theory. I think it's a phytoandrogen the way that soy is a phytoestrogen. So I don't think it actually increases your natural testosterone production. I think it acts like a bad, weak version of a plant-based steroid. So that might give you an impression of how you will feel with more androgens. But again, if you just spike your androgens, it's going to be dopaminergic. and it may not be consistent with how you would feel long-term on TRT if you did a trial of Tongat Ali. So I think Tongat Ali is a scam. I think it has always been a scam. I think that it may produce some beneficial short-term acute subjective effects, like energizing effects, kind of like, gelatinized maca. I think that it falls into the same category as that. But is it something that guys should be taking long-term to support or increase their testosterone levels? The only people saying that are people who are selling it. So I don't know anyone who supports Tongat Ali who doesn't make money off it.
Okay.
And I have a marketing degree, so I can say that affiliate marketing is a huge business. And if you're looking for the benefits of something, look at what the people who are saying who aren't selling it are saying. Because if everyone who's promoting it if everyone who's supporting it is also selling it, it's bullshit.
Right. I had a lot of men asking me about chronic fatigue, chronic tiredness. I know some men personally. They've been on TRT for years. They've tried everything. They are not overweight. They are in fine, but they're always fatigued, and thyroid levels are normal. Is there anything else they look into for chronic tiredness on TRT? Should they optimize even or try to augment thyroid levels to try to get rid of that?
Yeah, it's a tricky one. General fatigue is quite a hard thing to pinpoint because there are so many things that can cause it. And there are multiple different things that can contribute to it. So, if you've got 10% from here, 10% from there, 10% from there, you can have a problem. So people are often looking for the one individual thing that's causing an issue. And a lot of the time in the human body, just like a car, it's multiple things causing a problem, multiple things wear and tear. So if someone's got fatigue issues, firstly, you've got to look at the quality of the sleep. So sleep apnea, big one, or just generally poor quality sleep from psychological stress and stimulant use. Phosphatidylserine is my favorite compound for supporting sleep because it's non-sedative, works on stress hormone levels, and is generally healthy for the brain and very well tolerated. So first thing to start with is good quality sleep. That goes without question. And then beyond that, vitamin D levels, waking temperature in terms of looking at their thyroid. So their thyroid levels might look good, but what are their waking temperatures? As I said, vitamin D levels and DHEA, those ones are really big. And then looking at the quality of the diet, the amount of sunshine, the amount of exercise, or liver disease, getting a liver ultrasound, checking for alcoholic fatty liver disease. There's usually something in that department. Malnutrition is a big one in terms of just people not eating good quality food and not eating enough good quality food. There's usually something in one of those departments that is off. DHEA levels being suboptimal is a big one for fatigue.
Let's round this up, Dave. One last question there. Can you please recommend a reputable TRT provider in Sydney, Australia, or I am clinic?
I will not disparage the clinic that you mentioned, but I also would not recommend going with the clinic that you mentioned. Are there any good providers in Sydney, Australia that I could recommend? No. We are not spoiled for choice in Australia. If you send me an email to dave@advancedfundamentalhealth.com, I can send you a referral to a clinic that I partner with. They will be your best option for getting access to a private script for injectable testosterone. In Australia, it's quite like we tend to, when I say we, practitioners in this country tend to either give like a 5% cream or Reandron, Libido, which is administered by endocrinologists. You want to avoid that. If you go onto this channel, I've done a lecture called TRT in Australia. You want to watch that and learn about the public health system in terms of how testosterone works in this country. But the most important thing that you can do is to get yourself access to a prescription for either testosterone cypionate or an ante, and then work with ideally your provider on dialing that in, or you can check out my ebook in terms of guiding and how to guide that in. But yeah, I can't recommend one on here because I don't know of any. We are not spoiled for choice in this country.
Okay. So how can people, Dave?
Yeah, so people can reach me via my website, advancedfundamentalhealth.com. I've got booking links on there. I've got an ebook available as well, and I'll have another ebook available within the next few months.
I leave the link in the description of this video, guys. Check that out. Okay, so the thing that rests me is to thank much for doing this, and for the viewers, Dave. Thanks.
Thank you for having me.
Okay, I'll wrap this up here.